This is a video shared by Dr. Felipe Lucato from Salvador, Brazil. In this video, a 61-years-old male patient with a single-piece IOL dislocated to the vitreous cavity was submitted to a new procedure to IOL Exchange. Prior to surgery, a preoperative examination confirmed the integrity of the anterior capsular support, allowing for surgical planning to remove the dislocated IOL through a corneal incision and replace it with a 3-piece IOL implanted in the ciliary sulcus. A 25-gauge system with chandelier light was used for this surgery. The procedure began with the removal of the anterior vitreous near the iris and around the IOL. In cases where there was a dropped nucleus or a dislocated IOL, inducing posterior vitreous detachment could prove more challenging. To address this, triamcinolone was used to stain the vitreous, and a perfluorocarbon liquid bubble was placed above the posterior pole to prevent macular trauma. After shaving the vitreous base using a scleral depressor, the surgeon tries to hold the IOL with a 25-gauge retinal forceps with the goal of bringing it to the anterior chamber and removing the single-piece IOL. However, despite the effort, the surgeon encountered difficulty in securing the IOL, causing it to slide and drop again during the maneuver. Note that even when trying to hold the IOL optics carefully, the friction generated between the lens and the retina in the mid-periphery causes local trauma, with iatrogenic tearing and bleeding. In order to more effectively retrieve the dislocated IOL and bring it to the anterior chamber, the surgeon opted to switch out one of the trocars for a 23-gauge one. This decision was made with the intention of improving the accuracy and stability of the maneuver. To place the IOL in the anterior chamber, the surgeon used an anterior chamber forceps held in their right hand, inserted through the corneal incision. This step requires the utmost care to avoid damaging the capsular support. One helpful technique to prevent a repeat dislocation of the IOL into the vitreous cavity is to position one of the IOL haptics outside of the corneal incision. This maneuver enhances stability during the IOL cutting and removal process. Following the IOL retrieval from the anterior chamber, it was cut using an anterior chamber scissor, employing the Pac-Man technique, and then removed through the corneal incision. To replace the dislocated IOL, a new 3-piece IOL was implanted above the iris, and the haptics were cautiously positioned in the ciliary sulcus. Following the corneal suturing, the surgeon resumed visualization of the retina using the BOM system. At this point, the surgeon observed remnants of the posterior hyaloid adhered to the posterior pole. The vitreous was then removed, and the iatrogenic break was treated with laser. The vitreous base was also checked again during the procedure. Ultimately, the surgeon elected to utilize 20% SF6 gas as a tamponade agent at the conclusion of the surgery. If you want to watch details and clinical discussions of this and other surgical cases, join the Orbit community and have access to all Orbit ophthalmo learning content.